So first, I talk about potassium physiology. Basically, potassium, stay in the cells. 98% of body potassium in the cells. Okay, the normal level of the we check the potassium level about 3.5 to 5 is the normal. Okay, it is absorbed by intestines, but excreted by the kidneys. Which cells in the kidneys excreted potassium mainly? Principal cells in the collecting tubules. So I talk about three major factors in slide 3: increase in plasma potassium level, increase in aldosterone secretion, enhanced delivery of salt and water in the distal potassium secretory sites. Okay, and then go to slide 4. Okay, so we ingested the potassium. It's taken by the cells, basically stored in muscles and liver. So when you check the potassium, different potassium level in muscles, liver, muscles are the highest storage organ in the body to store muscle. So when you have a rhabdomyolysis, physical exercises, a lot of potassiums are released, and you can have a hyperkalemia from rhabdomyolysis associated with the acute kidney injury. And I talk about the sodium potassium ATPase in the cells, which form out of the 3 sodium out of the cell and 2 potassium into the cells. Okay, so these activities are facilitated by insulin and beta-2 adrenergic receptors. So that's the basic principle. So when you have a relative insulin deficiency, like fasting, you can have a mild hyperkalemia, because insulin is required to drive potassium into the cells. So fasting can cause relative insulin deficiency, and it can cause mild elevation in potassium level. Usually in dialysis patient, sometimes we let the patient fasting, or patient came in with a small bowel obstruction. Oh, we cannot operate on these days. Okay, we dialyze. Let's say in the United States, we dialyze the patient on 3 days a week. Either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Oh, this patient have the dialysis on Monday, but we're gonna operate on Tuesday. So we let the NPO. Okay, if you don't give a D5 water or D10, fasting can cause potassium leak out. You will see my hyperkalemia like 5.6, 5.7. Okay, and another thing is, one of the treatment in the acutely lower down the potassium is beta-2 adrenergic agonist, like albuterol. If you give albuterol naps, you can drive some of the potassium into the cells. Why is that? Beta-2 adrenergic receptors activity is important for sodium potassium ATPase. And also, beta adrenergic receptors blockers can inhibit the renin release as well. So you have a hyporenemia, hypoaldosteronism too. Okay. Got it. Okay. This is the principles I'm talking about. You can see this is the sodium channel. This is the principal cells. In the middle principal cell, this is the tubular lumen. This is the interstitial space towards the kidney. So you can see the sodium level. We call it ENaC channel, epithelial sodium channel, ENaC, ENaC. So sodium channel, you can see the sodium potassium ATPase, 3 sodium out of the cell, 2 potassium in. Here is the aldosterone, famous guy. So, okay. And then when you have an increase in plasma potassium level, there is an increased secretion of the aldosterone. So aldosterone binds the aldosterone receptor. Okay. And then it increases the absorption of the sodium into the distal principal cells. So there is a more sodium inside the cells. So sodium has also cation. So there is a less cation in the luminal space, in the urinary space. So more cation needs to go out of the cell to go into the urinary space to lessen the electronegativity. So if you have a sodium reabsorbed in a principal cell, you have to secrete potassium through the Rampke channel or regular potassium channels. Okay, so we usually learn about in the medical school, potassium sparing diuretics, right? Spironolactone, alprazolam, amiloride, triamterene. Okay, Spironolactone and aldosterone are basically aldosterone antagonists. Okay, and they are amiloride and triamterene. They are the ENaC channel blockers. When you give amiloride and triamterene, it blocks sodium absorption from the epithelium sodium channel called ENaC channels, so that it blocks sodium absorption. So it means that indirectly it blocks potassium secretion. So potassium will increase. That's the mechanism. When you give somebody to spironolactone, for example, chronic systolic congestive heart failure, you trying to get down the renal angiotensin axis. Okay, there is a spironolactone, there is still aldosterone production, but it gives you the aldosterone resistance, because when the aldosterone binds the aldosterone receptor, aldosterone effect cannot occur. It decreases the potassium secretion. So when you give a spironolactone, aldosterone, you can have a hyperkalemia. Okay, let's go to next one. Okay, we eat every day, right? Banana, avocado, oranges, potatoes, tomato. So we have a normal creatinine less than 1. So why we don't have a hyperkalemia? Hyperkalemia is very rare occurrence in normal individuals. Why is that? Okay, our colons are fine, intestines are fine, we absorb high potassium load, but kidney is very smart enough to excrete potassium into the urine. So hyperkalemia is very unusual in normal individuals because our urinary excretion of potassium is very good. So when you have a hyperkalemia, you start to have a suspicion. Oh, is he or she have something to do with the kidney function? What is the GFR? Usually, urinary potassium secretion is maintained, even though GFR is above 30. You can still maintain, but less than 30, 20 ml per minute, your urinary potassium excretion of potassium is start to go down. Or patient has an aldosterone deficiency or aldosterone resistance, or the patients on like I said, mentioned about aldosterone antagonists or potassium sparing diuretics, things like that. So we have to think about that. So increasing potassium intake is matched by increased urinary excretion. So normal diet is about 100 milliequivalent per day. You can excrete that. Even though you increase to 400 milliequivalent, kidneys are still small. It will increase the plasma potassium excretion, and then aldosterone more aldosterone will be produced. So where is the aldosterone produced? In a zone, in the adrenal cortex. Okay, so in this way, potassium are excreted. So basically, these are the 3 different mechanisms. Once you eat more potassium, there is a way for potassium adaptation facilitated by 3 mechanisms. I mentioned about that. Number 1, increased activity of the epithelial sodium channel called ENaC. It will be dependent or independent of aldosterone. And increase in density and activity of the secretory potassium channel, and also increase in sodium potassium ATPase. Let me go to the picture. That's what I'm saying. When you have a potassium load, it will increase in sodium channels, and it will increase in sodium potassium ATPase activity. So more sodium out of the cell and more potassium into the cells, but those potassium will be eventually secreted by the potassium channel here. So if you remember these 3 things, you'll have a very easy life to study the potassium physiology. All the medications are based in the physiology. So like I've already mentioned, the potassium intracellular cation controlled by sodium potassium ATPase. Why it is important? Why are we talking about that? People don't know when your potassium is 5.56, you're going around in the community. You don't know. You start to feeling weak. If you have a hypokalemia, you have remember the potassium is stored in skeletal muscle. So your skeletal muscle will be weak. More importantly, cardiac membrane can sense the hyperkalemia. You will know that cardiac membrane, there will be a negative disturbances in the conduction system too. So you will see the tall and tender T wave, PR interval will be lengthening, and then later on P wave will disappear. And then you have QRS complex and T wave will merge together. We call it sine wave. And then you will have a VFib, atrial fibrillation, and you will have a cardiac arrest and you will die. So it is important to manage the potassium level above 6. Especially in a CKD patient and dialysis patient, their cardiac membranes are very accustomed to low degree of hyperkalemia. So it is very dangerous. They won't feel anything. You won't see any EKG changes with potassium 5.5, 5.2. That's a normal baseline for them. But when they start showing up EKG abnormalities above 6, especially in CKD patients and ESRD patients. So, okay, so here are the causes of the hyperkalemia. I adopt these slides from up to date. So they put the pseudo hyperkalemia. You can see the first cause in the increased potassium release. Actually, pseudo hyperkalemia, when you see somebody potassium, you don't, find the cause. So in that case, okay, what's the cause? It could be the pseudo hyperkalemia, not a true hyperkalemia. You have a blood draw, you put a tourniquet, but there is more tissue damage or hemolysis in the blood samples. You can have a mild potassium elevation. So the answer is you repeat the blood test if you suspicions of the pseudo hyperkalemia. Another one is if you have a leukocytosis more than 70,000 of the white cells and very severe thrombocytosis more than 500,000 cells, things like that. Because remember, the potassium is stored in intracellularly. So when you have an increased amount of cells, either white cell, platelet cells, you're going to find the high potassium. And the metabolic acidosis. Metabolic acidosis you will find in the chronic kidney disease, stage 4 and beyond. And why is that? Metabolic acidosis again decrease the potassium secretion in the distal collecting ducts. So metabolic acidosis prone you to have hyperkalemia. So that's why you see both hyperkalemia and metabolic acidosis in advanced renal failure. Okay, that causes insulin deficiency, hypercalcemia, and hyperosmolality. You see, every word here has a very meaningful meaning. Why is the mechanism for you see the hyperkalemia and hyperglycemia? Hyperglycemia is increase the osmolality in the serum. So it draws the water out of the cells to compensate it. In that case, there is more relativity of the potassium inside the cells. So it needs to go out of the cell. That's why, you will see the hyperkalemia and hyperglycemia. The same thing when you have insulin deficiency, either fasting or insulin deficient diabetes, you will find a hyperkalemia. Another thing is hyperosmolality. Why is that? If you give a mannitol to decrease down the intracerebral blood, pressure, you would same mechanism. It drags the water out of the cells. So it's relative increased concentration of potassium inside the cells. So some potassium needs to go out of the cells. That's why you will see the hyperosmolality induced hyperkalemia. Okay, number 4, increased tissue catabolism. Like when you have a cancer, you get a chemotherapy, you will have a tumor-lysis syndrome. Potassium stay inside the cells. Potassium will be leaked out of the cell. You will see hyperkalemia. And you have a rhabdomyolysis. You exercise. Oh, okay, I'm very motivated today. I will do running about 2-3 hours in the, on the broad daylight. So you will have a rhabdomyolysis, things like that. And a beta blocker. It is very rare in my experience, but still, like I said, beta blocker can inhibit the renin secretion, and it will be decreased aldosterone secretion. And then again, exercise can lead to increased catabolism. Another thing is there is a channelopathy, and then there is a hyperkalemia. It is familiar. You will find the hyperkalemia, kalemic periodic paralysis. At the same time, you will see the hypokalemic periodic paralysis to people will be very, very flaccid. And other causes, you will sometimes you will have anesthetic agent too, cysteine, things like that. Another thing is, I rarely see this this age of medicine, but you will see still the digoxin, given to the patient systolic heart failure. The digoxin can cause the hyperkalemia too. Why? Because it inhibits sodium potassium ATPase in the distal tubules. So that's why you will find the hyperkalemia and digitalic toxicity. Okay, that's the increased potassium release from the source. So this, to put it in the two major category: increased potassium release from the source. So you will find hyperkalemia. Another one is, like I said, intestines are very less significant to excrete potassium. So kidneys is the major organ to excrete potassium. So when you have a reduced urinary potassium, you will find the hyperkalemia. So we already mentioned about the aldosterone is the major key player in the kidneys distal convoluted tubule, because aldosterone stimulate the potassium channel to excrete potassium, and also it increase absorption of sodium through the neck. And also aldosterone stimulates the sodium potassium ATPase in the basolateral membrane of the principal source. But here they basically go in 4 categories. If you have a reduced aldosterone secretion, reduced response to aldosterone, and reduce the distal sodium and water delivery. This is kind of like a nephrology term. Decrease, distal sodium water delivery means you have a decreased effective arterial volume. Let's say, for example, you have vomiting and diarrhea for many times. You're truly intravascularly depleted, truly decrease effective arterial volume. So in that case, you will have a less fluid inside your blood vessels. So you will present less sodium and water to the distal tubules. So you have a less chance to absorb sodium because your body has depleted. So you have a less chance to excrete potassium. So you will see in the hemorrhagic shock, hypovolemic shock, things like that. And in other words, you will see in the pre-renal failure, acute or chronic disease. Basically, in the chronic kidney disease, there is a decreased nephron mass, decreased activity of the sodium potassium ATPase, and also the ureate toxin can inhibit the sodium potassium ATPase in the distal tubule. So that can cause hyperkalemia. And I will explain a selective impairment in potassium excretion, Gordon syndrome, later on. Okay, next slide. So we talk about the reduced aldosterone secretion. Here is a reduced aldosterone secretion and aldosterone resistance. So you will find why the aldosterone is decreased. Okay, because there is a less renin. Why is that? Okay, for example, you have a diabetes for let it go and controlled. And then you will have a diabetic nephropathy after 5-10 years later. So you will have a less renin secretion. Renin is excreted in the kidneys. So if you have a kidney problem, of course, you have a less renin secretion. Less renin secretion lead to hypoaldosteronism. And also the NSAIDs, non-steroidal anti-inflammatory drug. We think, oh, this is a benign. Okay, I take ibuprofen. Okay, maybe once in a while for aches and pain, maybe, but don't take chronically, more than 2-3 weeks and not more than 1 or 2 tablets, because it is not a benign drug. It can cause a lot of things. NSAIDs block the prostaglandin, right? So prostaglandin is very important to have the potassium secreted through the distal tubule as well. So when you take the ibuprofen a lot, it can cause hyperkalemia because blocking the prostaglandin stimulation of the collecting that potassium secretion. Also the calcineurin inhibitor. These are the medication we use for kidney transplant, like tacrolimus, cyclosporin. These medications acting like a digitalis too, it inhibits the distal sodium potassium pump, so it can increase the potassium. Another one is volume expansion. This is very simple. Why renin is produced less? Usually there is a less blood pressure, decreased blood pressure, or less volume. Renin is increased so that it can increase the production of the aldosterone, which can cause salt and water retention. So if you have volume expanded state, volume overloaded, you don't need to produce the renin, or you produce less amount. So these are the causes of hyporenemic hypoaldosteronism. Oh, there you go. This is a major actor. We love our ACE inhibitor, of course, lisinopril, captopril, whatever pril. So we give that, and then it inhibits angiotensin 1 to angiotensin 2 receptor blockage. So you will have a less angiotensin 2. And then you will have a less aldosterone secretion. In that case, potassium will increase. Usually we don't use renal inhibitors that much later on, less current, but we use a lot of ACE inhibitor because it, facilitate the cardio remodeling. It is very good for systolic heart failure, diastolic heart failure. So we love to use it because these are the cardioprudent medications, but it can cause hyperkalemia, especially they give us a lot of headache, especially patient has a congestive heart failure and advanced chronic kidney disease. Later on, we find a way, I will tell you guys. But these, just right now, remember that angiotensin inhibitors and also the angiotensin receptor antagonists like losartan, irbesartan, that can cause hyperkalemia too. And there you go, chronic heparin use, either from the anticoagulation or chronic bedbound patients, we use heparin subcutaneous 5,000 2 times or 3 times a day to prevent the deep vein thrombosis. Again, sometimes you won't find any cause for the hyperkalemia. There is no ACE or ARB or potassium sparing diuretics, but patient is getting heparin. Heparin can cause hyperkalemia because it blocks the aldosterone synthase. Another thing is adrenal insufficiency. Of course, adrenal insufficient, it blocks all the synthesis of the aldosterone, cortisol, and sex hormone. So it is no-brainer. Severe illness, again, it can lead to adrenal insufficiency. Another interesting inherited disorder is that there is cases of 21 hydroxylate deficiency. It can cause hypoaldosteronism. And then pseudo hypoaldosteronism type 2 Gordon syndrome. This is a kind of like a zebra questions. Usually you find in the nephrology board. Gordon syndrome is a little, complicated because usually in the distal convoluted tubule, you absorb sodium. In Gordon syndrome, there is an activation of the Wnt kinases, through NK kinases. It stimulates the salt and water absorption in the distal tubule called NCCT, sodium chloride cotransporter in the distal tubule. So it is activated. So when you have more absorption of the salt and water, you have to excrete potassium. But in this disorder, Gordon syndrome, potassium cannot be excreted. So you will see the hypertension from salt and water retention, hyperkalemia from inability to excrete potassium, and hypertension, metabolic acidosis. Okay. So go to pseudo hypoaldosteronism type 1. In this case, you have a mineralocorticoid receptor problem. So in this case, you will find you will find normal blood pressure because you will have a losing the salt through the kidney tubules. You will have a hyponatremia, but you will find a hyperkalemia. So the common thing is pseudo hypoaldosteronism type 2 has hyperkalemia, but Gordon syndrome type 2 has hypertension. Pseudo hypoaldosteronism type 1 has normal tension or low blood pressure, and hyponatremia because of salt wasting. Okay. And then another interesting thing is you probably see the obstetric uropathy all the time, prostate problem, bladder cancer, things like that. Why you will see the hyperkalemia? Because you will find a problem with the potassium excretion. So in the principal source, so you will find hyperkalemia, like obstetric uropathy, lupus nephritis, sickle cell anemia, renal amyloidosis, things like that. When you have inflamed interstitial renal tissue, you will find a difficulty in potassium excretion. Okay, there you go. These are the potassium sparing diuretics. It falls into the category of aldosterone resistant. You can see that here. Ooh. Okay, so when you give a potassium sparing diuretic, spironolactone, alprazolam, it blocks the aldosterone receptor in principal cells. It blocks potassium secretion. Okay, and then but you will see some hyperkalemia when you give a Bactrim for the subcellulitis or things like that. Why is that? There's two components in the bacterium. Trimethoprim component blocks the potassium excretion, so it indirectly causes aldosterone resistance. So you will see that my hyperkalemia. Okay, so these are the two major classes in the potassium sparing diuretics. So in my medical school, I don't know that that's different. So I want you guys to understand that. Number one, aldosterone antagonist. It competes with aldosterone receptors. It blocks the potassium secretion, so it increases the high potassium. Another thing is drugs that directly block ENaC channel. ENaC means epithelial sodium channel and luminal membrane of principal cell, like amiloride and triamterene. Uh, these two differences are more important, important in the inherited disorder of salt and water. So when you have amiloride, we can use amiloride in GRA, glucocorticoid remediable aldosteronism, things like that. So I will talk about later. So we have to understand the inherited salt and water disorders as well. So these two types. Basically, I'm happy if you guys know two types. One, aldosterone antagonist. Number two, ENaC inhibitors. Another one we give you guys here, pseudo hypoaldosteronism type 1. It falls into the aldosterone resistant. What is the mechanisms? So there are basically two disorders, autosomal recessive and autosomal dominant. So if it is affect the mineralocorticoid receptors, there's the aldosterone. Aldosterone still bind the mineralocorticoid receptor, but that receptor doesn't work. They didn't recognize aldosterone, so they cannot function like aldosterone in around. So there is less potassium secretion. It can cause hyperkalemia. Another one is ENaC channel problem. So ENaC channel is not working properly. So it cannot absorb sodium into the cells. So potassium cannot be excreted into the urine. So these are the two major mechanisms. Basically, this photo, you will see it a lot. Your memory will memorize everything. When you have a mineralocorticoid receptor problem, you cannot excrete potassium out, so hyperkalemic. When you have a ENaC problem in a pseudo hypoaldosteronism type 1, no sodium can be absorbed, so there is no way potassium to be excreted, so there is a hyperkalemia. So this, I want you guys study the pictures. I like pictures. So this picture is very important. Make your life a lot easier when you learn about potassium. Another one is voltage-dependent renal tubular acidosis. Again, the same thing. Why why this is important? Because when you absorb sodium from the ENaC channel, sodium has a cation. So there is a less cation in the lumen, in the urinary space. So there is a more electronegative. Okay, so that promotes hydrogen ion and potassium into the lumen. Okay, but if you have impaired sodium absorption, you will have a less potassium excretion and hydrogen ion excretion, so leading to metabolic acidosis and hyperkalemia. This causes voltage-dependent renal tubular acidosis. I show you guys the slides in the aldosterone resistant category. It falls these medical conditions like urinary tract obstruction, lupus nephritis, renal amyloidosis, interstitial disease, sickle cell disease. They can have a renal tubular acidosis. When you have a CKD, you will have some form of renal tubular acidosis too, because of this problem, impaired sodium absorption. And I didn't put it in my slides. I want you guys to study the intercollected cells too. In the intercollected cells, sodium, potassium will be reabsorbed to prevent hypokalemia, and then hydrogen ion are excreted in the lumen. So if you have an RTA, less hydrogen ion can be excreted in the intercollected cells in the distal tubules. So you can have a metabolic acidosis. So you will see not only hyperkalemia, you will see metabolic acidosis when you come across the renal problem. That's why they are very common. Okay, there you go. Another category we talk about aldosterone, hypoaldosteronism, decreased response to aldosterone. Now there is a reduced sodium and water delivery. I talked to you guys before. There is a decreased effective arterial blood volume. So there are two categories. One is true volume depletion. I hate to use dehydration. Okay, dehydration is basically means just water. You let water out of the body, water alone. It doesn't follow by sodium. If it is you lose sodium and water, it is called, we call it volume depletion. Okay, you sounds like a more like a nephrologist. So true volume depletion, either GI or renal losses, like you have a diarrhea, renal losses, you use a diuretics. For example, if you use thiazide diuretics, thiazide inhibit the NCCT, sodium chloride co-transporter in the distal tubule. And like loop diuretics like Lasix, bumetanide, things like that, they inhibit the sodium potassium chloride channel, then the ascending loop of Henle. If you use this kind of things, they probably, if over diuresis, true volume depletion. Another one is you still have blood volume, but you have a decreased tissue perfusion. That's meaning that you have kind of like a arterial blood volume depletion. For example, systolic heart failure. Your heart, the pump cannot pump the blood out of the heart enough. So you will have the kidney consume the 25% of the cardiac output from the heart, okay? So you have a heart failure, you will have a less sodium and water, less blood presented to the kidneys. So you will have a decreased delivery of the salt and water to the potassium secretory sites. So you will have a less excretion of potassium out of the body. In other words, into the urinary space, you have a hyperkalemia. So this is the heart failure. Another one, you will see the cirrhosis and you will find some hyperkalemia. You guys probably know the, and cardiorenal syndrome and hepatorenal syndrome in cirrhosis. Okay, in hepatorenal syndrome, there is a splenic vasodilatation. So even though you have a blood volume, but you have vasodilatation, you have a relative blood volume in the blood vessel space. So you have a less presentation to the kidneys, less blood volume. So in that case, decrease potassium secretion and hyperkalemia sets in. Okay, we love ACE inhibitor to use in the heart failure. In that case, if you have a worsening heart failure, if you continue to use the RAS inhibitors, you will find the hyperkalemia. Okay, and then spironolactone, we love to use in the cirrhosis of liver. But when you have a really worsening cirrhosis of liver, worsening liver failure, you will find hyperkalemia. So you have to hold spironolactone in that case. And we will see in the daily practice chronic kidney disease, acute kidney injury, things like that. I told you before, in the chronic kidney disease, there are 5 stages. GFR above 90 is stage 1. GFR 62, 90 is stage 2. 30 to 60 is stage 3. And 15 to 30 is stage 4. So when you stage 5 is less than 15 ml per minute per 1.73 meters square. So when you have a CKD, still maintain the potassium excretion, even though you close to the stage 3, that's fine. But if you are stage 4 and stage 5, if GFR is less than 20, in that case, you have a problem with potassium excretion. So in that case, you can have a chance for hyperkalemia to come in, okay? So especially when you have acute kidney failure from any causes, acute tubular necrosis, when patients have oliguria, and then a patient's a high potassium diet and increased tissue breakdown. A lot of the ICU patients, we have to use the Nepro tube feeding. If somebody use regular ensure, things like that, it has high potassium. Especially patients have oliguria, less than 500 cc per 24 hours. And patients are, they are bed-bound, intubated, things like that. In that case, more tissue breakdown. And then when the body is sick, you probably have adrenal insufficiency. In that case, reduced response to aldosterone, things like that. So when you have a renal failure, either acute or chronic, you have prone to have a hyperkalemia. In the uremic stage, ESRD or CKD stage 5, your uremic dioxins can block the synthesis of the sodium potassium ATPase, and your vital pumps functions can be impaired too. So it's very important. Okay, this is a kind of like a more clinical practice. You have several factors to decrease urinary potassium excretion. Sometimes when you have a systolic heart failure, you use a spironolactone ACE inhibitor or ARB, angiotensin receptor blockage. And you know that CHF by itself can decrease the renal perfusion, leading to distal sodium delivery. In that case, if you use a medication, hyperkalemia get worse. So that's why starting from the systolic heart failure or late stage of CKD, you start to use diuretics. It increases the potassium excretion from the kidneys. If you have a mild CKD, you can use thiazide. If you have advanced CKD, late CKD stage 4 and 5, I rather use loop diuretics, which are stronger, like a Lasix or furosemide or bumetanide. Okay, I told you guys about some selective potassium excretion. For example, lupus, transplant rejection, sickle cell, they have a selective impaired potassium secretion in the principal cell. That's why hyperkalemic. The same thing goes along with tacrolimus and cyclosporin. And then I briefly talk about Gordon syndrome. They have a problem with the inhibiting the sodium chloride channel in the distal convoluted tubule. So it is hyperactivated and more sodium absorbed, but potassium cannot be excreted. So you have a hyperkalemia, hypertension from volume expansion from sodium resorption, but they have a normal creatinine. And you will sometimes see the ureterojejunostomy. You put the ureter in the jejunum. Why is the hyperkalemia in those patients? In the urine, you have a potassium, but those potassium are reabsorbed from the jejunum. That's why. Okay, clinical features, like I said, it rarely gives you the signs and symptoms, but once you have a potassium above 6, 7, you will still, start to feeling weak and things like that. But most importantly, muscle weakness, and more importantly, ventricular arrhythmia. So initially above 6, you will see the tall and peak T wave. We call it tentative wave. And then a contraction abnormally kicks in. You will start to see the PR interval is prolonging, and then P wave is start to disappear, and later on P wave is totally gone. We call it atrial standstill. And then later on QRS is lengthening, depressed ST segment. Later on above 8, you will start to see the sine wave marching the T wave and QRS complex. And then I'm sure you will see the ventricular arrhythmia and asystole. So hyperkalemia is very, very dangerous because you don't feel anything apart from the just generalized body weakness. So we talk about pseudo hyperkalemia already. Usually you find during the blood draw technique and hemolysis, you will see in the leukocytosis and thrombocytosis. Usually you don't find any cause and you don't suspect anything, no EKG changes. So repeat the potassium level, no brainer. Acute rise in potassium, and we already talked about something going on. If you see the acute rise, potassium was 2 weeks ago, 1 week ago, 3.54, and then now 6. Something going on. He doesn't have a white counts are normal, or no hemolysis during the blood draw. But kidneys are very smart. If you increase the potassium intake to 400 milliequivalent per day, it doesn't cause hyperkalemia. So in that case, you definitely have a problem in increased release of potassium from cells or decrease potassium excretion from the kidneys. These are the two major causes. Okay, so you have to find the patient has a car accident or tissue crash injury, rhabdomyolysis, or patient got a chemotherapy, things like that. Or another thing is hyperkalemia can cause hyperkalemia, right? Hyperglycemia cause hyperkalemia. In the DKA, you find the very hyperglycemia, it forms into the non-organic acidosis, DKA, diabetes ketoacidosis. It can cause hyperkalemia by itself from the hyperglycemia, but usually DKA intravascularly volume depleted, you will find acute kidney injury. So both two causes can cause hyperkalemia. So you will find a persistent hyperkalemia. First of all, you will make sure there is no renal deficient. If patient is on the ACE or ARB, if patient is taking heparin or not, if patient is taking cyclosporin, tacrolimus, or patient is taking NSAIDs chronically. Fine for the medications. That can cause urinary potassium excretion from the mechanism of decreased aldosterone or decreased response Or another one, check the basal metabolic panel, check creatinine, whether patient's acute kidney problem or not. So we need to know the baseline creatinine. We talk about what is the baseline creatinine. Oh, doctor, creatinine is 2-3. Okay, I don't want to know that. I can see. But what is the baseline creatinine a week ago, 2 weeks ago, last month, things like that. So we have to talk about our patient is volume depleted or not. Our patient has other associated conditions that can cause hyperkalemia, like congestive heart failure, cirrhosis of liver, things like that. So two common medication we need to look for is patient is on spironolactone or ACEI or ARB. Because spironolactone can cause decreased aldosterone response. ACE inhibitor or ARB can decrease aldosterone secretion. So like I said before, so we have to reduce the potassium intake, but we have to increase potassium excretion out of the body, either loop or thiazide diuretics. So I intend to use, loop diuretics when the kidney failure stage 3, 4, 5. And also it is the best practice to use a low dose diuretics or appropriate dose if you use ACE inhibitor or ARB in heart failure too. We usually use a furosemide or bumetanide. Bumetanide 1 milligram is equivalent to furosemide 40 milligram. And sometimes if volume overload is too much resistant to loop diuretics, we add metolazone, which is the distal-acting thiazide-like medication. So you can have a more effective diuresis. So basically, diuretic means getting rid of potassium from the body. Okay, hyperkalemic emergency. When you have a potassium above 6.5 and above is hyperkalemic emergent. Sometimes you have start to see the ECG changes, tall and tender T-wave. These are the hyperkalemic emergency. Sometimes when you have a moderate hyperkalemia, potassium above 5.5, but you have a ESRD or you have a CKD stage 4 and above, significant cardiac dysfunction, you need an urgent treatment. Urgent treatment means you have to do the calcium. Usually I use calcium gluconate to stabilize the cardiac membrane because hyperkalemia predisposes you to have a cardiac contraction problem. We intend to use IV insulin. If blood glucose level more than 250, don't give insulin. That's fine. But if your blood sugar is less than 250, you want to use glucose with insulin because to avoid hypoglycemia. Again, hypoglycemia is lethal and fatal in short time. So we need to be careful about that. Why do we use insulin? Because it drives potassium into the cells. Okay, it promotes the sodium potassium in ATPase, so more potassium into the cells. So we need insulin to drive potassium into the cells urgently. But these are the three main mechanisms you will learn a lot. Loop diuretics if kidney function is not severe, because loop diuretics, they act in the ascending loop of Henle. So you should have an adequate GFR because these diuretics are excreted in the urine. So these medication needs to go to urinary space and block the sodium potassium chloride channels in the ascending loop to be effective. So if you have a kidney failure, if you give a thiazide diuretics in ESRD, it is so annoying because it won't work, believe me. And then if kidney function is severe, creatinine is 4-5, you consider hemodialysis to actively remove the potassium. And then you decide patient should be on chronic dialysis or this is acute dialysis. Another one is, like I said, GI is not a major role, but still we use it to prevent the potassium absorption. We traditionally use a KXLA, which is the SPS, sodium polystyrene sulfonate. These two medications, Lokelma and Veltesas, are new kids on the block. Lokelma is a kind of crystalline which absorb the potassium. It exchanged with the hydrogen ions and sodium. It's called Lokelma. Veltesa is a pyrroma, so which is kind of like an inorganic, non-absorbable polymer, but it exchanges the potassium and calcium in the gut. Okay, so basically we look for the reversible causes of hyperkalemia. If you find the medications, hold the medication, NSAIDs, ACE inhibitor, ARB, hold heparin subcutaneous if we can. And another thing is reduce the, effective arterial volume. If patient is truly volume over, depleted, you give a normal saline. So sometimes we give the normal saline and diuretics, because when you give a normal saline from diarrhea or vomiting, it presents more sodium to the distal tubules and more potassium can be excreted. So along the way, you have to put the patient on the cardiac monitor. You have to check the sodium 2 hours after the treatment. Basically, you give a IV calcium gluconate. Usually, I tend to choose calcium gluconate over calcium chloride, because calcium chloride can cause some tissue irritation. So that's why I like a calcium gluconate. Usually, I give a 1 gram. It adds in 1 to 3 minutes right away. It stabilizes the cardiac membrane, but effect is very short life, about 30 minutes to 1 hour. So you can repeat it. You can recheck the potassium every 1 or 2 hours, but you have to put the patient on the cardiac monitor. This is the why, I like calcium gluconate over calcium chloride. So we already talked about the why we give the glucose with the insulin to prevent hypoglycemia. If serum glucose is more than 250 milligram per deciliter, we don't need to use glucose. Insulin can be given alone too. So usually I give a regular insulin 10 units IV followed by 50 ml or 50% dextrose, meaning that 25 gram. When you have 100 ml or 50%, which is full dose, 50 grams. So we have a 1 ampu, which is a 50 ml. So this is a 25 gram. Okay, so the effect of insulin begins in a few minutes later, 10 to 30 minutes, usually peak at a 30, 60, but it affects, lasting for 4 to 6 hours. It can drop the potassium 0.5 to 1. So we can repeat when the effect is over. So usually for the acute thing, we have to consider IV calcium gluconate plus IV insulin, followed by dextro, 50% dextro, 50 ml. These are the rapid measures to control the cardiac membrane and to control the potassium, driving the potassium into the cells. But these are not definitive mechanism. Here it goes. This is the definite mechanism. You have to get rid of the potassium through the GI tract by using the gastrointestinal cation exchanger, the spatiroma, which is the Valtessa, and zirconium cyclosilicate, which is the low karma. Okay. And this is the SPS, sodium polystyrene sulfonate, which is the K-oxalate. Later on, we try to avoid the K-oxalate because of it's associated with the bowel necrosis. Dialysis is the most effective way to remove the potassium. If potassium is above 6 and creatinine above 4, 5, we start to consider about dialysis. Of course, meanwhile, we have to give calcium, insulin, and also if patient is still urinating, we give a high dose of Lasix, Bumex 2 milligram, one-time dose, or Lasix 80 milligram, things like that. At the same time, we use sodium zirconium cyclosilicate, which kind of like a phosphorus binder, which binds the potassium in the gut, so the preventing the potassium to be absorbed systemically through the GI tract. But it has a sodium, so you can, I think, twice to use a sodium zirconium if somebody who comes with a volume overload, either from renal failure or cardiac failure, because it has a sodium. And if you can use a diuretics with the saline, if patients have a normal or mild to moderate impaired kidney function, I would say mild to moderate impaired kidney function is up to stage 3. Like say creatinine is less than 2, and patient is a little hyperkalemic, not volume overloaded. So you can present with the IV saline, probably low dose, 60 or 80 cc per hour, and you give diuretics. So basically the purpose of giving IV saline is to present salt and water to the distal tubules. And then once you reach there, loop diuretics prevent the reabsorption too. So you dampen more sodium and potassium out of the body. In hypervolemic state, like stage 5 and above, and plus they have a heart failure, they are hypervolemic, checks X ratio, pulmonary edema. In that case, don't give IV saline. You can use Lasix or bumetanide alone. You can use a 40 BID, TID, depend on the GFR. Like I said, once you have a reduced GFR, you will have a reduced secretion of the diuretics in the tubules. So you have to pound with the hammer. You have to use a high dose of diuretics. In the euvolemic, hypovolemic, you can use a saline or you can use an isotonic bicarb. What is the isotonic? Sodium is 140 to 135 to 140, give or take that. So if you have a saline, so 154 milliequivalent per liter. So isotonic bicarb means you have to give 3 amps of bicarb. So to make it 150 milliequivalent. So this is called isotonic. Okay, so we talk about the real hyperkalemia emergency. Potassium is 6, 7. Creatinine is very bad, 4, 5. We bind the time, give calcium and insulin, and we give GI and cation exchangers because we're waiting for the to put the temporary dialysis catheter. But after that, we do the dialysis. Okay, and these are the two new medications on the block. So this is Patiroma and sodium zirconia. So we already talked about that. We try to avoid the SBS, KXLA because of the bowel necrosis, especially when the operation patients, bowel obstruction, ileus, underlying bowel disease like ulcerative colitis. We try to avoid that. Okay, so if patient without hyperkalemia emergency, we can use the same mechanisms, GI and cation exchanger, plus or minus dialysis if patient has a severe kidney dysfunction. We try to avoid dialysis if they have a mild to moderate kidney dysfunction. Up to the GFR less than above 30, we try not to use dialysis. So we try everything, saline infusion, diuretics to get rid of the potassium renally. We use Localma to get rid of the potassium from the gut and to prevent the potassium absorption, things like that. And you look for the causes. Patient is intravascularly depleted or not. If patient is on ACE or ARB or aldosterone, things like that. But at the end of the day, if potassium really acutely high hemodialysis is the best way because it's most efficient way to remove the potassium. It can remove about 25 to 50 milliequivalent of potassium per hour. So, but this is systemically we're talking about. So I will stop my presentations here. It takes so long. I will take any questions.